Good afternoon. My name is Brianna Castro. I am an FTO paramedic with Cumberland County EMS, and today I'm going to be going through some of the neurologic emergencies that we see in the pre-hospital setting. This is not a completely comprehensive PowerPoint or lesson. It does have some things that just for time's sake we're not going to be able to cover, but this gives us a good kind of baseline understanding of some of the things that we might see in the field, and some treatment plans that go along with that. So there we go. Learning objectives for today. By the end of this PowerPoint, we will be able to recognize common neurologic emergencies in the field. That's going to be our cognitive domain. We're also going to be able to perform pre-hospital assessments, which is psychomotor, prioritize and initiate our evidence-based treatment and transport decisions. This is going to be dependent, obviously, on what service you work at and what resources are available. We'll be going over how to communicate with receiving staff about patient condition and treatment priorities and treatments that have been administered in the field. And then also we'll talk a little bit about recognizing these, the importance of why we should recognize these treatments, and also provide compassionate care for these patients. So before we get into our emergencies, I figured it would be a good idea to do a little bit of an anatomy refresher. So starting with the nervous system. So the nervous system is separated into central nervous system and the peripheral nervous system. So the central nervous system is going to be your brain and your spinal cord. And then your peripheral nervous system is going to be your cranial and spinal nerves, your peripheral nerves. The central nervous system processes any information, so it comes out from your peripherals, sends it up to the brain, to the spinal cord. It gets processed there, and then on vice versa, commands come out from your brain and they go out to your peripheral nervous system. So that's really the central hub. Your peripheral nervous system is further broken down into your autonomic and your somatic nervous system. So your autonomic is going to be your heart, the smooth muscles of your intestines, things that we don't have any control over, right? We're not actively thinking to make our heart beat. We're not actively thinking to make peristalsis happen in our intestinal tract. Those things just happen on their own. And then our somatic nervous system is going to be all of our voluntary muscles. So I can flex my arm, I can move my fingers, I can shake my head. That is all voluntary and is controlled by skeletal muscles. And then if we break down the autonomic system even more, you have your sympathetic and your parasympathetic. So sympathetic, we all know, is fight or flight, right? That gets activated. It's a evolutionary thing that we've developed, but that increases our heart rate, stops digestion. It will dilate our pupils to let more light in. That's something that just happens naturally if we're in a state of excitement. And then parasympathetic is your rest and digest. So when we are in a relaxed, safe environment, our body will naturally kick up GI. It'll kick up reproductive functions, things like that. And then different types of neurons. We have afferent, which are your sensory. The way I was taught this and remember this is afferent goes to your afro. So those are the ones that send signals up to your brain. And then your efferent are your motor neurons. So they send commands out to your body. And you can see in the diagram here, I think you can still see my clicker. They do have different shapes because they have different functions. The brain specifically, that's our hub, right? That's where a lot of things happen. And we'll go into quite in depth about different areas of the brain and different functions that it has. It's really important for us to have a good general understanding about these things because it will help with determining where problems are rising, right? So if we understand the functions of a specific area in the brain, that will help us to recognize what area is being affected by, say, a stroke, by, say, a seizure, things like that. So the brain as a whole is split into three parts. You have your cerebrum. That's your big brain. That's when we think of brain, that's typically what most people think of. And this controls movement, temperature regulation, speech, emotions, learning, different functions. It's split into a left and a right hemisphere. And you'll hear people say things that you're left-brained or you're right-brained. And so those have different kind of typically functions, left versus right, but they are able to communicate across the corpus callosum, which is a deep sulcus. It's a deep, um, almost like a valley in between. And so they can communicate across that. Then we get into the brain stem, which is shown in orange here on the picture. Your brain stem is going to be where a lot of our very basic functions come from. So the brain stem is very primitive. That's the word I'm thinking of. Very primitive functions happen in your brain stem. And again, super important for us to recognize that because when we have patients who have injury to their brainstem, a lot of their primitive life functions cease to function as normal. So your brainstem is further separated into three. The brain likes threes. Your brains or your midbrain, which is hearing and movement, responses, environmental changes. Your pons, which is tear production, chewing, blinking, focusing your vision, balance, and then your medulla breaks it down even more primitive, more basic functions, right? Your heart rate, you're stimulating you to breathe, stimulating gas exchange, things like that. So the brainstem is super important in regulating those bodies and trying to keep us in homeostasis, which is at the end of the day what our bodies want to be in. And then you also have your cerebellum, which means little brain. And so that's right here in the back, and that coordinates a lot of muscle movement, balance, equilibrium, things like that. So those are the big kind of general areas of the brain and their functions. And then we get into further subdivisions of the brain. Again, these lobes, these are typically separated into lobes and they're super important, right? So that we know, right? Occipital stroke. So if we know that the occipital region is typically used in vision or visual memories, if we have a patient who's experiencing visual disturbances, we have a higher index of suspicion that there may be something going on with their occipital lobe. So that's occipital. Parietal is going to be hanging out right here on the sides. This is your touch, texture, and tactile memories. Temporal is our temporals. Hearing, smell, the memories of those things, and then also has some to do with language. The frontal cortex, right? So frontal lobe is split into two, so motor and prefrontal. Motor cortex is our motor functions, right? Voluntary muscle control. Prefrontal cortex, I'm sure I've all heard a bunch. Prefrontal cortex doesn't develop until you're in your 20s. This has to do with understanding consequences, abstract functions, right? A lot of emotional regulation and judgment and things are stored there. And then also part of the brain, we have the limbic system. Again, very primitive, right? Basic emotions and basic reflexes, chewing, swallowing. And then your diencephalon is actually subdivided even further into the thalamus and the hypothalamus. So the thalamus is a relay center, and then your hypothalamus is super important because it plays a really important role with your endocrine system and your hormone functions and your body's releasing of hormones and things like that. So again, it's a lot of information. The brain's super important. It does a lot of things. So having a little bit of a general knowledge idea of what areas do what things will help us to have high index of suspicion or grasp of where the injury might be happening within the brain. So strokes. Time is brain. Strokes are probably one of the more common calls that we see in EMS, and they present in a lot of different ways. They're also very time sensitive. So in a stroke, essentially, there is not perfusion to the brain appropriately, whether that is ischemic, so from a clot of some sort, or hemorrhagic, and there's bleeding within the brain. These are very time sensitive. It's very important that we are able to quickly identify that this is what is happening to these patients and then transport them to the appropriate facility because their lives they depend on them. So strokes, you can have ischemic, which is where a clot forms. Now they can be thrombic, which is where you have clotting in the area that's affected. You also can have embolic. So an embolism that moves somewhere or that develops somewhere and then moves to the brain, right? So we talk about DVTs can be very dangerous because they're clots that form in the legs, but they travel up towards the heart or to the brain. You also can have embolic clots from amniotic fluid in pregnant women. So that's another thing to be mindful of, is that pregnant women can have amniotic fluid embolisms that, could potentially cause a stroke. And with these ischemic strokes, they administer fibrinolytics, so TPA, and those are administered within 3.5 to 4 hours is typically the time frame. There's a little bit of discussion on when exactly it is. So they say generally 3.5 to 4 hours. Then you have your hemorrhagic strokes. So hemorrhagic strokes, you can have a few different types, right? Depending on where within the brain they are bleeding, and also where in relation to the coverings of the brain there are. So you can have an epidural hemorrhage, right, which is above the dura mater, epi above mater, dura mater. 2/3 of these are going to be arterial, 1/3 of them are going to be venous, and they're typically characterized with a brief loss of consciousness. So an injury happens, they lose consciousness, and then they regain consciousness. Subdural hematomas, these are slower because they are typically venous blood. So they're not doing the squirting arterial high pressure system bleeding. They're typically slower bleeds and they have a sudden onset of symptoms. So these patients were really worried about like our falls, right? We have elderly patients that fall, or maybe not elderly patients, right? Maybe just patients, or they're in a car accident, or they have some sort of traumatic thing that happens. They hit their head. They don't lose consciousness. They feel perfectly fine. They don't want to go to the hospital. And then, say, a couple days later, right, once the bleeding starts to accumulate, now there's pressure, now there's poor perfusion. These are patients that can have very serious deficits. And then subarachnoid hemorrhage, these are going to be your sudden onset, thunderclap headache, worst headache of my life, strokes. That is what these patients are. And then in the picture here, you can see kind of in relation to where the dura mater is and where the bleeding falls for each type. So with strokes, we are very concerned with large vessel occlusions, or LVOs. These are a clot of some sort in a major artery. So typically these are seen in the ICA, the MCA, PCA, these major arteries that feed the brain. These are large vessel occlusions. In our stroke screen, which we'll get into next, they actually added the G. So instead of the FAST exam for the Cincinnati pre-hospital stroke, a lot of places have started adding G, which is gaze deviation. And gaze deviation is actually going to be most predictive of an LVO when you're doing your stroke screen. So if you have a patient who has a gaze deviation, you should have a very high index of suspicion that they have a large vessel occlusion. And then we talked a little bit about TPA earlier for thrombic strokes, ischemic strokes. With something like this, an LVO, typically endovascular thrombectomy is going to be preferred. So a brain surgeon will go in and remove the clot. Super important, again, to recognize because that may determine where you're going to be transporting these patients and what capabilities are available in your system. And then this picture just shows really well, like this is their normal brain. You can see that the occlusion is right here. So it is cutting off this entire area of blood flow from the brain. And then after they do the thrombectomy, you can see how blood flow is returned, and they see that with contrast. Okay, stroke screens. How are we going to know that these patients are having stroke, right? What are we going to use? What tests are we going to use in the field to determine, hey, is this person having a stroke? Am I going to call it a code stroke? Right? A little bit of that will depend on your system and your service. So at my system, we use BFAST. And so I have added that in here. Some places may use the Cincinnati. Some people may use the Los Angeles, right? It'll be service dependent. Please refer to your protocols. But this is just, I wanted to go over kind of an example of what that would look like. So BFAST is what we use in my service. B is balance. So was there any sort of sudden onset of loss of balance or coordination? Or is there any onset of ataxia? So to test this, you can have a patient take their finger and touch their nose, and then touch your finger, and do that with both sides. You also can have a patient take their heel of one foot. We'll say this is my heel, this is my leg, and this is my foot. You can have them take their heel and scrape it down. You also, right, depending on the patient and where they're at, you can have them try to stand and take a few steps, maybe to get on your stretcher or your stair chair, to see if they're having any difficulty, right, finding out where their feet need to go, any difficulties with the coordination. E is eyes. So any sudden onset of vision difficulties, blurred or double vision, specifically on one side, but I mean it could be on both, right? Depending on where the injury is. So asking them that. You also, excuse me, can test their field of vision. So a lot of times you can take your fingers, right? I would have, say, purple gloves on, take their fingers and move them and see if their peripheral vision comes in at the same time, if it's equal, right? You may have a person who doesn't realize that they have right-sided visual neglect until you go to move their hands, your hands behind their head, and they say, oh, I can see this one, but I can't see this one until it's out here, right? That would be a new onset of a visual deficit. Face, do they have any unevenness, numbness, or drooping? So you can have them smile, show your teeth. You can have them raise their eyebrows. You can have them stick their tongue out. All of those things to check to see if things are moving evenly and equally. A is arms. So is there any sudden numbness or weakness to one arm? And then we have patients take their hands, put them palm up in front of you. You put them up, close your eyes, keep your arms upright. Does one arm fall? Do both arms fall? Does one of them kind of wiggle? They have difficulty keeping it up. That would be positive for arms. Speech, any slurred speech, difficulty speaking, finding their words, understanding what you're saying. These can be some of the most interesting stroke patients if you've never experienced that. So typically you'll ask them to say a phrase, right? Repeat after me. You can't teach an old dog new tricks. And so if they start saying, can't dog tricks, oh, okay, what? Also, they can have, it can affect Broca's aphasia. They can have Broca's aphasia. And there's some other different types of aphasia where they have difficulty speaking. So if I hold this up and I tell my patient to identify, like, what is this? And they say cat. And I say, well, what is this? And they say blue. That would be indicative. And then the T is time. It also is terrible headache. So, right, we're subarachnoid hemorrhages, those thunderclap, worst headache of my life. T would be indicative of that. But we want to know when these symptoms started and what their last known well is. Strokes are time sensitive. And so a lot of times we see patients who have wake up strokes. So they feel fine when they went to bed and then they wake up and now they're having these symptoms. Well, we don't know what time that started. So we use their last known normal. Well, what time did they go to bed? Okay, you were fine at 10 o'clock last night when you went to bed, right? Now that changes. Say they got up at 3 o'clock in the morning and had to go to the bathroom. Okay, well, were you fine at 3 o'clock when you went up to go to the bathroom, or were you having some of these problems? So it's really important for us to be able to kind of work through and differentiate when the time is, do a little bit of investigative work. The other side of the screen here, we have the fasted screen. This is going to give us our indications for LVO. So I think I might be in front of it. You might not be able to see it, but right up here, any score that's greater than 4, we're going to have a high indication, high probability of large vessel occlusion. So facial palsy, right? If they don't have facial palsy, that's a 0. If they do, that would be a 1. Arm weakness, right? Normal arms both hold up, that's 0. They can raise their arms, but one drifts down, that would be a 1. Or if both of their arms fall rapidly, that would be a 2. Expressive aphasia, so asking patients to identify objects. If they can get 2 or 3 of them, that would be a 0. If they can't get any or they can only get 1, that would be a 1. And then receptive aphasia, so you ask them to do something, right? Touch your nose, right? Grab my hand, hold this pen, some simple task. If they're able to do it, that's a 0. If they can't do that, that would be a 1. Again, time, right? We want to know what their last known well was. We want to know when the symptoms onset, as much information about that we can get, because that's going to indicate if our patients maybe qualify for TPA or if they qualify for these thrombectomy treatments, right? A lot of this is time dependent. Eye deviation. So they can look around, normal field of vision, that would be a 0. Difficulty to one side, that would be a 1. Or if they have a complete gaze, that would be a 2. So you may have a patient who can follow you all the way to the left, and then when they're tracking their finger, they can't go past midline to the right. That would be a 1. Or if you have a patient who has a completely deviated gaze, they will not follow your fingers. Their eyes are stuck looking to one side. That would be a 2. And then denial or neglect. So if they have an arm that has weakness, right? Do you feel the weakness? If they can feel the weakness, that would be a 0. If they don't feel weakness, but they obviously have weakness, that would be a 1. And then neglect, if they don't recognize their own arm, right? So if you are like, whose arm is this, right? You show it to them, their affected arm, and they're like, that's my arm. That would be normal. If they're like, I have no idea whose arm that is, that's not normal. People typically can identify their arms. So that would be a 1. So any combination of these things, it's a lot of information, but any combination of these that gives you a 4 or greater, we're going to have a high index of suspicion that they have a large vessel occlusion and should be transported to the appropriate destination as such. Does that make sense? I would ask the class, does that make sense to everybody? Any questions up till this point? No? So now we're going to watch a quick video. It's like a minute and a half about the Cincinnati stroke screen. Like I said, this is just another one that people will use. So Cincinnati is just facial droop, arm drift, and speech. But we will actually watch. We're going to watch it be performed.
The Cincinnati Stroke Scale is made of facial droop, arm drift, and slurred speech. Have the patient smile and show you their teeth.
Sir, can you smile and show me your teeth?
If both sides of the mouth are symmetrical, this is considered normal. If one side of the mouth drops, as demonstrated in this illustration, this is considered positive. For arm drift, have the patient outstretch both arms with their palms up. Have them close their eyes and ask them to keep their arms in place.
So I need you to stretch your arms out, with your palms up, close your eyes for me and hold your arms out.
If one arm drifts down, this is considered positive. Lastly is a measurement of their speech. Have the patient repeat the statement, "You can't teach an old dog new tricks."
Can you repeat after me? You can't teach an old dog new tricks.
Can't teach an old dog new tricks.
If the speech is clear, this is considered normal. If they slur their speech, this is considered positive.
that just shows how we would perform that on a patient. Oh, all right. I guess we'll move on. So, Cushing's triad is another important concept and topic for us to have a good general understanding of when we're talking about neurologic emergencies, because these are going to be our clinical signs and our vital signs that we're seeing with any increased ICP, so increased intracranial pressure. Typical pressure within our skull, right? It's a closed, hard area. So we don't like a lot of pressure. Normal pressure is about 5 to 15 millimeters of mercury. That's can have some normal variations, right? If we sneeze or we're coughing or there are some, normal variation things that can happen. But typically we like to hang out right at about 5 to 15. Your body works really hard to keep it between 5 and 15. When we begin to exceed 15 and get into greater amounts of pressure, right, this is when these symptoms start to occur. So a lot of times this happens from hemorrhage, so bleeding rather traumatically or spontaneously from an aneurysm. Could be from a tumor. Um, those are things that it commonly occurs from, but it can also occur from, right, if you have a head injury, but you don't have bleeding, but now you just have swelling, right? Or you have an ischemic stroke and now you're getting edema in the brain. And so you're getting fluid and different swelling, hypoxia. There's some different things that can cause there to be increased pressure, right? Blood, fluid, air, things like that are not supposed to be there. Cushing's triad is a late sign, and it indicates brainstem herniation is a common. So remember we talked about brainstem and how that's super important for our very primitive life functions. These patients who are exhibiting these symptoms, they are going to be having some very not great symptoms pretty soon after. So what is Cushing's triad? Cushing's triad is 3 signs, right? Triangle. You're going to have a decreased heart rate. You're going to have a wide pulse pressure, and you're going to have irregular respirations. Typically, this happens when your intracranial pressure exceeds your MAP, your mean arterial pressure, and because your blood pressure is increasing to try to perfuse your brain, to try to maintain cerebral perfusion. And then it notices that the pressure is really high. So your heart rate starts to drop down to compensate for that. And it can affect your respirations, and your systolic and your diastolic will start to get further and further apart. So pre-hospital, there's not a ton that we do for this, right? In the hospital, they'll do mannitol. The biggest things that we can do is try to keep the head elevated at about 30, 35 degrees. In school, they teach you to, if you're manually ventilating, to ventilate to hyperventilate with an interval of about 30 to 35 to help with some of the pressure and CO2 and stuff like that. Typically, this is not anything. We're just going to be doing symptomatic management for these patients, but it's important to recognize the severity of their head injury and where they're at. Before they maybe become altered or unresponsive, right? They could be weak, headache, vomiting, blurred vision, sudden changes in behavior, those kinds of things. All right. Moving on from strokes, seizures are another very common emergency that we see in the pre-hospital world. And this happens from sudden erratic firing of neurons. These have all sorts of symptoms. There are all sorts of different types of seizures. No 2 seizures look alike. We can separate them a little bit into like generalized versus partial. So generalized, you're going to have your tonic-clonic, that's your grand mal, or your grandma seizures. Some patients say like, I got them grandma seizures. This is what they're talking about. You're going to have a tonic phase where they crunch up, and then a clonic phase where they have contractions of their large muscle groups. We also have pseudo seizures. These are psychogenic non-epileptic seizures. These are still seizures. I'm not talking about the fakey shakies that people do. I don't love calling it that, but like fake seizure activity, right? These are actual seizures, and your patients are not causing this behavior, right? This is happening to them typically from some sort of psychiatric history or PTSD or things that have happened. These are real seizures. Please treat your patients accordingly. Pseudo seizures are seizures. And then you also can have absent seizures. Formerly were called petit mal. We see this a lot in children, and this is when they just kind of have a blank stare. So there's no real tonic-clonic shaking movement. They just, like, lights are on, but nobody's home for a few seconds. And typically these are diagnosed, right, in our younger children, and they do EEGs and all that kind of stuff. So those are your generalized seizures. Partial seizures, you can have simple or complex. The big difference is, did your patient have a change in their mental status? And then, super interesting, if you've never seen it, is Jacksonian March. So the neurons will start firing in one area of the brain, and it spreads almost like a pebble. Drop a pebble in a pond, and it kind of moves out. And so they'll start seizing maybe in their fingers, and then it moves to their arm, and now it's their whole arm. And so you can kind of watch as it develops. And then status epilepticus is defined as greater than 5 minutes of seizure activity without stop, or 2 or more seizures without a return to baseline. This is a medical emergency. This is not good, right? Because especially if we're having like these grand mal seizures and they are not ventilating appropriately, they maybe become hypoxic, they can endure pretty significant neurologic damage from prolonged seizures. So management, treatment, pre-hospital, BLS before ALS, right? So preventing aspiration, protecting their head, ventilating if necessary. Hypoglycemia can cause seizures, so we want to correct that if that's a problem. And then on our more ALS side, paramedic side, right, giving IM or IV benzodiazepines if the patient is actively seizing. We do not give benzodiazepines as a preventative in case they might have a seizure. We give benzodiazepines to actively stop the seizure they're having. And then in there, I just put also, like, a lot of times these patients will have a postictal period and they'll be confused and they'll be repetitive and they may become combative. Treat these patients with kindness, right? Be very gentle with them. It's okay to explain to them multiple times what happened because their brain just went through a lot and they are going to take a while sometimes to come out of it and to regain, back to their normal baseline mental status. We want to know maybe how long the seizure lasted. Can bystanders describe what the seizure looked like? Do they have a history of seizures? Are they pregnant? Are they diabetic? These are all good differentials that'll help you kind of rule in or rule out what type of seizure that they may have had. A couple medication names to be aware of. Anticoagulants. So super important for us to know for our stroke patients, right? If they're taking any blood thinners. Coumadin, warfarin, Eliquis, apixaban, Xarelto, heparin. Those are a lot of the pretty common anticoagulants, right? They're going to increase the risk of bleeding, decrease the ability to clot. So if they're having a hemorrhagic stroke, they will bleed more intensely than someone who maybe is not. Seizure medications, also important to be on the lookout for, right? If we're trying to figure out like what's going on with this patient, if we don't have someone who can give us a good history. So Lamictal, Keppra, Dilantin, Topamax, Vimpat, these are all very common seizure medications that your patient may be taking. And then diabetic medications, right? Metformin, glimepiride, Humalog, Novolog, Lantus. These will clue you in that, this patient is diabetic. And so we need to check their sugar, which we should be checking sugars on older patients anyways. But these should really be your, like, hey, red flag, this patient is diabetic. Or, hey, red flag, this patient has a history of seizures. Maybe they had a seizure. Not to say that that's 100% what's going on, right? Because people have events outside of their diagnosed history. But it'll clue you in more onto the big picture of the patient's history and who they are. Okay. AEIOU tips is a very common mnemonic for altered mental status. I also have heard move stupid, MOVESTUPID is another one. This is just a good thing to keep in the back of your mind when we're talking about our altered patients and you're trying to really, like, figure out what's going on with them, right? So you're trying to rule in and rule out your differential diagnoses. This is a good one to keep in the back of your mind. So each of these, right? Alcohol, acidosis, epilepsy, endocrine, opiates, they're going to have their unique signs and symptoms. And these would maybe be some things that will kind of red flag in your brain, like, oh, this patient, um, let's say, let me pick one. They have constricted pupils and they're altered and they're breathing 4 times a minute. And maybe they're a little cyanotic around the lips, right? That would be indicative of an opioid overdose. Um, or if you have a patient who has a fever and a rash and they're tachycardic and they're tachypnic and okay, well, maybe they're septic, right? They have some sort of infection. Let's maybe look and see if they have a wound of some sort that I can see. Or how do their lungs sound, right? Do they sound like maybe they have pneumonia? And that's could be our presumed source of infection. So this is just a good way to keep an eye out and help you rule things in and rule things out when you're in the midst of your patient assessment and you're like, what do I think is going on with this patient? I always try to keep it in the back of my head and like run through on my altered patients. And then I also really like this altered LOC algorithm. So this comes from the Nancy Caroline Emergency Care in the Streets textbook in the Neurologic section. I could not find that picture, so I had to recreate it. But it's figure 18-15, chapter 18, figure 15 in that textbook. But this goes through, okay, our patient is altered, right? Do we think it's medical? Do we think it's trauma? And then we can follow down, okay, so it's trauma. Do they have a head injury? Is there mechanism of injury? Do they have elevated ICP, right? These are things that we would be looking for with these. Or on the medical side, right? Okay, so it's medical. We don't think there's any obvious signs of trauma. Was it rapid onset? Did it just happen now all of a sudden? Or is this something that they just haven't really been acting right for the last couple of days, right? And so this gives you another visual to go through your differentials and kind of the things that you're going to see for each one. So they have a history of kidney disease. Maybe they're in kidney failure. They'll have electrolyte changes and EKG changes. If um, their blood sugar is low, right? Maybe they took too much insulin. It just is another way to kind of visualize and help because people can be altered from such a wide variety of conditions that it is good to have a visual that we can refer back to. So GCS is a way that we score patients' mental status, GCS and AVPU. AVPU is typically for our more medical patients. So are they alert and awake? Are they alert to or awake to verbal stimulus, painful stimulus, or are they completely unresponsive? GCS is typically reserved for our trauma patients. In my service, everybody gets a GCS. That's just how we do things. Doesn't really matter what your complaint is. We're basing your GCS. So GCS is broken into eyes, verbal, motor. It's 4, 5, and 6. And then you get a total score. So we'll do a couple practice questions so you guys can see. But we add up their total score and that will give you your GCS. So start with the first one. 28-year-old female, closed head injury, moans and bends her arms toward her chest, points her toes forward. When you attempt to splint her upper extremity fracture, what is her GCS? So she moans. It says nothing about her eyes opening, so that would be eyes of 1. Moaning, incomprehensible sounds, that would be a verbal of 2. And then she has decordicate posturing, which is also known as flexion from pain. That would give her a motor of 3, so her total GCS would be a 6. 56-year-old male, unconscious, not responding to verbal or painful, and he has decordicate posturing. So eyes are a 1, verbal is a 1, motor, again, that kind of flexion is a 3. So he would be a 5. 30-year-old homeless on the sidewalk, opens eyes to painful stimulus, tells you to go away, pushes your hand. He would be a 12. And then these patients we see all the time, 85-year-old male in nursing home, greets you when you enter, speaking clearly, but he's a little confused and he's kind of rambling off topic. He would be a GCS of 14. So that just kind of gives you a picture of how those get broken down. Another thing to talk about, just kind of briefly brush over, is pupillary reflexes. So pupillary light reflex, or the PLR, is subcortical reflex, which is regulated by the autonomic nervous system, right? That's fight or flight. It can tell us a lot about how the brainstem is working. Abnormal pupillary responses can pinpoint location of lesions. I don't know of a ton of pre-hospital providers who are going to be identifying the area of a stroke based on pupils, but it is something uh, that's possible. And then fixed dilated pupils might suggest herniation. So this one is true. Patients will look at the side of their stroke. They will have a deviated gaze, or if they have anoscoria, which is shown right here in B, this patient may be having compression of the ocular nerve on the affected side, which could be caused by herniation in that side, right? They're bleeding on that side. It's causing a compression, which is why now their pupil is blown. You also can look at things like nystagmus, which is where the eyes shake. There's a lot of things that we can see with the eyes that'll tell us about the patient's neurologic. It's not the be-all end-all of neuroassessment. It's just another tool in the belt. So make sure you're assessing your neuro patient's eyes. Okay, communication and documentation. It's important for us to be able to relay information to the hospital staff, right? What happened? What did we see? What were we told? What did we do? This is a screen grab from ESO is the system that my service uses for our documentation. This is not our stroke screen, but this is an example of a stroke screen. So being able to document that accordingly of why we're calling things code strokes, right? What is the qualifying criteria for me to call this a tier 1 code stroke versus a tier 2 code stroke? Onset time, description of any witnessed events from us or by bystanders, right? Being able to relay that information. Any treatments that were performed, right? So did we give a benzo and now the patient is somnolent because they've just had 5 milligrams of benzodiazepine. And so now the hospital staff isn't able to do a thorough neurologic test or exam because the patient is now sleepy. Right? Did we give any Narcan? Documenting anything that we saw, anything that we were told, anything that we did will help the hospital be able to get a big picture of the patient's complaint and be able to provide them with the best care. Key phrases, last known well for our strokes, right? These are time sensitive. We need to be activating based on times. So making sure that we're really trying to narrow that down. How long a seizure lasted, right? Are we concerned that this is now getting into status E, or was this like a 10, 15-second episode that they had? And then if they were postictal, right? Especially if they're still postictal at the hospital, those are important. That's important information to be able to communicate to the hospital staff. Okay, so now we're going to do a case study and just try to kind of wrap all this information up. So you are dispatched to a local hotel for a desk clerk with altered mental status. You arrive on scene, BSI, your scene is safe. You arrive on scene and you see a 33-year-old male lying in a supine position on the floor behind the desk in the lobby. The patient is awake, but he has difficulty responding to your questions. He knows his name, but he doesn't know where he is, and he doesn't know the time or the date. So he's obviously confused. Getting into our primary assessment. His airway is open. There is no foreign body. He has no stridor, no vomit in his airway, no secretions, nothing like that. So open and patent. Breathing is non-labored, and his breath sounds are clear and equal bilaterally. He has a strong radial pulse that is regular, and his skin is warm, moist, and pink. So we obtain this patient's vitals. His blood pressure is 182 over 100, pretty elevated. His heart rate of 112, also elevated. His respiratory rate is 16. His pulse ox is 94% on room air, and his pupils are pearl, so they're equal, round, reactive to light. And then when you also are assessing a patient, you notice that he has some bleeding. from his mouth. So we'll get a sample history, signs and symptoms. We know that he's altered, he's confused, he's tachycardic. You also note incontinence of urine. And so since he's altered, we check a blood sugar, and his blood sugar is 120, which is normal, right? 80 to 120 is normal. Allergies, he says he doesn't have any. Medications. He doesn't know his medications, but you find a prescription bottle for Dilantin in his pocket. Past medical history, he doesn't know. Last oral intake, we don't know, but it's not of great concern right now, right? There's no airway compromise, right? That might be something we can get later. And then events, he doesn't know what happened, and nobody witnessed the incident. So they just found him on the ground, right? So with all of that information, what do we think maybe is going on with our desk clerk? So he's got some bleeding from the mouth, incontinence of urine, Dilantin in his pocket. Those would all be signs that would point me towards the idea that this patient had a seizure, an unwitnessed seizure. So treatments for him, right? What are we going to do? We're going to do C-collar and spinal mobilization, right? He was found on the ground. We're thinking maybe he had a seizure. We're thinking he fell, maybe hit his head, right? Could have hurt himself. Seizures can become pretty violent. So we're going to go ahead and do spinal precautions. Oxygen's a little low. He's not hypoxic per se, but he's a little low. So you would not be wrong to, give him a little bit of oxygen, 2 liters native cannula. And then for our advanced providers, right, we're going to want to give IV access. We're going to want to have this available in case he has another seizure, right? So that we can quickly administer benzodiazepines to stop the seizure. But again, we don't give benzos preemptively, only when patients are actively seizing. So what would be some differentials that we would be thinking about? Drug overdose, right? That can cause him to be altered and tachycardic and a touch hypoxic. That makes sense. Hypoglycemia, which we ruled out because his blood sugar was 120, but it's something that we could initially be thinking of, especially if he's, a little moist. He's a little clammy. He's a little tachycardic, same thing. And then stroke, right? We want to make sure that we'd be doing a thorough stroke screen on this patient, just to ensure that, it's not something that he had a seizure caused by a stroke, right? He had a stroke, caused damage to his brain, then he had a seizure, right? So we want to be doing a full neurologic exam on this patient. And then a couple of critical thinking questions to go over. How would the patient present during a postictal state? They might be unresponsive, completely out of it, sleepy, weak, disoriented. They also can have stroke-like symptoms. We see that a lot in pediatric patients. It's called Todd's paralysis. So after a seizure, they will have deficits on the side that was affected. Postictal states can last for up to 30 minutes. And this is when it's really important to make sure that we're being kind and considerate to these patients, because it can become frustrating to be repeating yourself, right? But if you have a patient who's in the back of the ambulance who's just confused, they don't know who you are, they don't know where they are, and then what happened? Oh, you had a seizure. I had a seizure. Yeah, you had a seizure. And then 45 seconds later, they're like, what happened? You had a seizure, right? It can become repetitive, but it's important to, be calm and be polite with these patients, because they genuinely are confused, and their brain's just trying to, make sense of their surroundings and what happened. And then some common causes of seizures. So fever, we see that a lot in pediatric patients. Febrile seizures, they can have infection, sugar problems, head injuries, stroke, alcohol withdrawal, dysrhythmias. People want to talk about VFib seizures, hypertension, eclampsia in your pregnant patients. So there's a lot of things that can cause a seizure. So we want to really be trying to root down to what caused this patient's seizure. This patient, it looks like he has a history of maybe epilepsy. He's got a prescription for seizure medication. So once he becomes more alert and can answer questions, right, he might be able to tell you, oh, I'm epileptic. Oh, they just changed the dose of my medication. So all of that to say, neurologic emergencies happen a lot. We see a lot of patients with these complaints in the pre-hospital system. So do your best to thoroughly investigate and try to get to the root of the problem, right? Have a good understanding of where the issue is being caused in their brain, right? Recognizing strokes quickly and transporting them to the appropriate facilities so that they can get the treatment that they need so that they can have the best outcome. If there are no questions from the group, I think that will conclude today's lesson. I have attached here just a couple of the resources, a lot of NCBI articles and things on different neurologic topics if anyone's curious on any additional research. But if there are no questions, we will call it here. I hope you guys have a great day. Please feel free to contact me if you have any questions about any of this information or want any of the resources or anything like that. Awesome. Have a great day.